So welcome everyone to our Q&A session today. Thanks very much to Dr. Andrew Yeoman, who's joining us today from Wales. Thank you very much for taking the time to join us again. We do really appreciate it.
That's a pleasure.
I always just like to say at the start as well, just to remember that these Q&As don't take the place of a consultation with your own clinician, and these sessions we're aiming to provide some general medical information and not medical advice. Also, please just be mindful that Facebook is a public forum. So if you're joining us on Facebook, if you're putting a question in there that's public, you can join us in the privacy of the room here on Click Meeting. The details of that were posted earlier. So what I'll do is I'll get started on the questions that we've had sent in for this week, and I'll also keep an eye on the chat here in Click Meeting and also on Facebook to see if there's anything new coming in as well. So we'll get to the first question. So the patient has decompensated cirrhosis due to asymptomatic undiagnosed PBC. What benefits are for them to be taking URSO? And there's also a question about once you test AMA positive. I wondered as well if you could just clarify the difference between compensated and decompensated cirrhosis.
Yeah, thanks, Mo. A really important question, this, isn't it? And I think so cirrhosis is a certain degree of fibrosis or scar tissue within the liver. And it has a broad range of clinical sort of consequences. So you can have cirrhosis and be extremely well, where you have good liver cell function and you don't have raised pressures around your liver, so you don't suffer any specific complications from the liver not working properly. But so that's what we call compensated cirrhosis, and most people with cirrhosis will be in the compensated phase, at least for a large period of time. And some people will progress on to develop decompensated cirrhosis. And I don't know if the presentations are still on the web page, Mo, but we've done talks around this before about what are the consequences of cirrhosis, and they largely fall into three major categories of symptoms. One is bleeding from the upper GI tract because of the development of something called esophageal varices because of pressure generated by the scarred liver. The second is ascites, which is a buildup of fluid in the abdominal cavity. And the third is hepatic encephalopathy, where the liver is not breaking down the toxins that it's meant to, and that affects brain function. But also there are other sort of more generalized consequences of having decompensated cirrhosis, and those include loss of muscle function, loss of energy and vitality, and often associated with malnutrition and I say significant muscle loss. So that's the difference between compensated and decompensated cirrhosis. The question was around what is the benefit of URSO if you have decompensated cirrhosis, and it's a really difficult question to answer in many regards. We haven't got good quality data and studies showing if it does change the natural history of, does it change the process of having decompensated liver disease. And certainly if you're being started on therapy for the first time, it probably does have a fairly marginal benefit, if any at all. But obviously it depends on how difficult the decompensation is to control. And sometimes we will often, if people can tolerate the medication, try and slow down the degree of ALP rise in people with PBC to see if that can improve liver function. But it's probably going to have a fairly marginal benefit, if any, once you have decompensated disease. But at the same time, it's often used if people can tolerate it, because if that ascites, for example, is managed with medication, and you can then concurrently reduce the ALP down to try and slow down the rate of damage to the liver, then that can also be a desirable thing. But I suspect for most people it'll have a fairly marginal benefit, but it's something that very much it should be a conversation between you and your healthcare provider about the relevant merits of continuing that medication, understanding all the nuances about the severity of the decompensation, and how the ALP is, etc., etc. So
and the next part of that question was, the patient was asking, once a person tests AMA positive, even if it flips back to negative, is it still considered positive? So once you're positive, are you always positive?
No, I mean, so autoantibodies, as we measure them in the blood, as we know, AMA is one of the antibodies that we can generate, that we will measure. They can fluctuate, and they can sometimes fluctuate even into the normal range. But I think if we come back, I think it relates to a question we're often asked, is if you come back to what constitutes a diagnosis of PBC, you had to have a positive AMA in your blood and an elevated alkaline phosphatase level. And the reason that's important is that some people can have an AMA that's positive but normal liver tests and will, may never develop PBC. And so just having the antibody on its own isn't enough. You have to have an elevated ALP. But if at any point in your life you've had an elevated AMA and a raised ALP, that would be considered diagnostic for PBC without requiring a liver biopsy. So we know that the amount of antibody that can be measurable in the blood can sometimes fluctuate above and below the detection limit. Okay. So when it's said to be negative, it's not actually completely absent. It's just at a really low level. So if some people have ever seen their blood values on a printout, it'll say things like 1 in 40, 1 in 80, 1 in 160, 1 in 320, 1 in 640. And what that ratio refers to is how much you have to dilute the sample before that antibody disappears. So in 1 in 640 means you have to dilute it 640 times before you cannot measure it any longer. So it's a way of quantifying the concentration of the antibody. So the higher the antibody, usually the more significant it is. But sometimes the level can just fluctuate above and below that detection limit. And normally the detection limit in most labs is set at 1 in 40. So it's just a quirk of how we measure things. So in most people, I bet if you looked hard enough, if you've ever had a positive AMA, if you kept on looking hard enough and looking at dilutions of 1 in 20 or 1 in 10 or 1 in 5, you'd probably still find it. So it's not truly lost. It's just gone below a threshold of detection the way the labs have diluted the sample. Does that make sense?
Yeah. And what about post-transplant? Do you remain AMA positive post-transplant?
Yes, probably. Yeah. I mean, I think, so I think a lot of people do. And I think, and again, because, you have, it's something that we measure in the blood rather than coming from the liver per se. So
that remains as well. That's great. Thank you. So moving on to our next question, it has a fair bit of background. The patient has PBC AIH overlap for 17 years and at present taken 50 milligrams azithromycin. Am I pronouncing that correctly? You just need to keep me right. And their LFTs are normal. In 2015, they tried to come off azithromycin, but had severe AHI flare, which took 2 years to stabilise, and they had to take steroids. Yeah. They've been told by more than one consultant that they need to take this indefinitely. However, their white cell count is low at the moment, 3.3 at the last blood test, but has almost always been between 3 and 4 regardless of the medication level, and only occasional normal. They've been told they need to stop taking it, but it's putting the patient under some stress as they don't want to further have any liver damage because they already have cirrhosis. Is there anything that you could advise around that?
Okay, so azathioprine is an immune suppressant drug, and it does affect the bone marrow, so it can reduce the production, particularly of white blood cells. And historically, if the white blood cell count has fallen below 3.5, then we'll often consider either reducing the dose of the azathioprine or stopping it altogether. I think if you look at the product literature, it does sort of state that, but actually what we're really mostly interested in is the neutrophil counts, because the reason it's important to consider the white blood cell count is if it goes too low, then you're at increased risk of infections. But actually within that white cell count, that's just an accumulation of lots of different types of white cells. So if you look, there's subdivisions then of white blood cells, and the really important subdivision is the neutrophil count. And generally speaking, if the neutrophil count is above 1.5, then there is, you can usually safely carry on azathioprine without any significant risk of infectious complications. And in some cases, you can even go as low as 1. And I think the practice of stopping routinely when you got to about 3 years, the total white cell count is a little bit outdated, but obviously I don't know what the specific subdivisions are for this particular person. But so if the neutrophils are okay, you can often carry on. But the other thing to consider in this situation is that, whether they might want to switch to a different medication, because there are other drugs that can control the autoimmune hepatitis component that this person has. And so some clinicians would prefer to, rather than run, albeit a very low risk of infection by having a slightly lower white cell count, might prefer to switch to a different drug to try and control the AIH component. So that's a discussion that they need to have. So if they want to stop that, what's the plan B? And it's perfectly legitimate. There's no good evidence that you should accept a lower white cell count, thinking that the risk is fairly low, versus switching to a different drug. So that's a conversation to be had between the person and their healthcare professional about which is the optimal strategy for them, because they'll have a lot more detailed knowledge about other aspects of their health and their liver condition. So I'd certainly share the anxiety of stopping it altogether. But in some people, as I say, the options is to accept a slightly lower white cell count as long as the neutrophils are okay. Option B would be to slightly reduce the azathioprine, and that will work for some people. And option C would be to potentially to switch to a different drug that doesn't affect the white cell count quite so much. But the other thing to consider as well is, why does the white cell count fall if you've been on this drug for a long period of time and seemingly okay on it?
That's actually the next part of the question, was just asking, should they be considering anything else that might be causing the low white cell blood count?
So actually, if you have liver disease, and particularly, not exclusively, but if you have cirrhosis, then that in itself can put your white cell count down. And there is one or two publications showing that actually the best predictor of a low white cell count in somebody with autoimmune hepatitis and a PBC overlap who is taking azathioprine, the best predictor of whether you will develop a low white cell count on the azathioprine is whether you've got cirrhosis of the liver. So in some people, not in everybody, but in some people, if they have cirrhosis, that will put the white counts down. And then it's not really the drug effect that's doing that. It's the fact that their liver's scarred and it's affected the spleen a little bit, and the spleen is pulling some of those white cells out of the circulation and reducing them in number. So there are other explanations as well, and that has to be borne into the decision making around whether you continue that drug, because you might just stop the drug, run the risk of flaring the condition up again, and actually still find you're in exactly the same position where the white cell count hasn't changed at all. In which case, you're probably better off accepting a slightly lower total white cell count as long as the neutrophil count is okay.
That's great, thank you. Next question is around a patient who's currently on the UK transplant list since August 2023. They're aware that it's impossible to put a time frame on when transplant is likely to happen. However, they've developed mild encephalopathy, and using the UK ELD calculator, their score is currently 56. They're asking if having I struggle to pronounce that as well, you need to keep me right, if that makes their score adds weight to their position on the transplant list.
Yeah. So the transplant benefit score is an algorithm which is used to try and introduce fairness and transparency around who gets allocated and where people sit on the prioritization list. Introduced in 2018, I think it was. So certainly been in place for a couple of years, and it has gone through some iterations. So the original iteration did have encephalopathy there as a recipient factor, because the transplant benefit score tries to match up the recipient with the donor characteristics. So it looks at the quality of the organ versus how ill the person is. So it puts all these things together to try and identify the best possible outcomes for people having a transplant. So in the first iteration, encephalopathy was in that. My understanding is in the second iteration, it's not there as a prioritization tool. But certainly I would always say it's important, if you're on the transplant waiting list and new things have developed, it is always important that the transplant team are aware of those things so that can be brought into the discussion. So as I understand it, in the second iteration of the transplant benefit score, encephalopathy is not there as a prioritization aspect. In regards to the MEL score, you have to have a minimum MEL score of 49 to be listed for transplantation in the UK, unless you have a liver cancer as the indication for transplant. But for most other people who are on the transplant waiting list, they have to have a MEL of 49. And historically, prioritization kicked in when the UKEL score, not MEL, sorry, the UKEL score was hitting 60. So at this point in time, it wouldn't do, but certainly it's always important that changes in clinical condition are reported, because that might be related to other factors within the transplant benefit score that would change the prioritization. And the other thing that really drives a lot of the stuff around what we've seen the transplant benefit score is that if you're older, you tend to get transplanted a lot quicker. Right.
That's good. Thank you for that. So we have a patient whose ALP was 104 in September and last week had gone up to 154. They take 750 milligrams of urso since diagnosis 4 years ago, and their ALP is usually around 104 to 120 max. Is it possible that their ALP could go back down? It just seems a steep rise in these last few months. And also, how soon should they repeat the blood test?
Yeah. So yeah, it does sound, proportionally it sounds a big increase, but in the grand scheme of things, in terms of the total elevation, it's still a relatively minimal elevation of the ALP. It's probably only around 15 to 20% above the normal range, although I accept that it is a 50% increase above your normal baseline. The important thing to remember as well is that PBC isn't the only thing that puts up an ALP. You can get, sometimes you get intercurrent infections that can put it up. They can be due to bone factors. If you've had a bony injury, for example, or a fracture, sometimes that can put it up. So there are other factors that can put up the ALP. ALP does sometimes fluctuate in PBC. I think the thing we always say is really important to do is to look to make sure you're still on a weight-based dosing of your ursodeoxycholic acid, because we know that you should be on a weight-based dosing. So if you've gained weight, that might be why the ALP has crept up a little bit. I certainly wouldn't be unduly alarmed by that sort of increase, because it's still in what we would call biochemical response criteria as they currently exist. So it still wouldn't be at a threshold whereby currently you'd be considered for second-line therapies, such as ursodeoxycholic acid or bezafibrate. And so it's not at that level that suggests you've really moved into a different risk category. But at the same time, it would be important to make sure you're on the right dose of urso. In terms of when to repeat it, there's no set sort of criteria. Generally speaking, I would probably check it within about 3 or 4 months, just to see whether the baseline has shifted a little bit. And sometimes we do find that the ALP does creep up over time. And if it is increasing, then obviously that might then be heading towards a threshold at which second-line therapies should be considered. But certainly there's no evidence that it's there yet. And I would say there's no pressing urgency to repeat the blood tests, but within 3 or 4 months would be a ballpark reasonable figure.
That's great. Just a reminder as well for patients that if they need the URSO calculator for their dose, that's on our website as well. You'll be able to download a copy of it from there. Or if you want a hard copy to take to your doctor, just give us a call and we can send one out. So our next question asks, can you provide any information about the autonomic issues associated with PBC? Is there any benefit in people with PBC having assessments at places like UCLH?
Oh, good questions today, Mo, aren't they?
We've got some crackers today, yeah.
Yeah, good for me. Autonomic dysfunction. So it's probably worthwhile defining what autonomic dysfunction is to begin with, because it's not a liver disease per se. So autonomic refers to the automated function of the central nervous system. So it's the part of the central nervous system that controls things which we have no control. So it controls heart rate, breathing rate, blood pressure, things like that. Okay. And temperature regulation, etc. So classical things people will get if they have autonomic dysfunction will be a dysregulation or an abnormal regulation of blood pressure. So prone to falling over or feeling dizzy on standing, for example, as the blood pressure drops when you stand up rather than rising to accommodate for a change in your posture. It might be thermoregulation, feeling extremely cold. And in some people, it can contribute to that generalized feeling of brain fog that people with PBC can have. The tricky bit with it is that it's not as well studied as one might think. I mean, there's clearly there's evidence that people with PBC do suffer from autonomic dysfunction, and lots of people with other chronic illnesses are more likely to have autonomic dysfunction than others. The question of how to manage it depends on really the symptoms and where people should go. So I think the allusion to the bit about UCLH is that they do have a very well-established service for people with autonomic dysfunction and these sorts of neurogastroenterology type thing. People have lots of gut problems related to, you can get gut problems with autonomic dysfunction as well. So they're a very highly specialist unit for that in the UK and probably worldwide. I guess it depends on the severity of the symptoms and actually what local services are available to investigate those symptoms. So I guess the commonest manifestation of an autonomic dysfunction would be dizzy spells and episodes of collapse or near fainting. And if that is occurring, then we would often do something called a tilt table test, because what you do is you're trying to almost stimulate that change in the blood pressure by exposing the body to different postures and measuring it at the time you're doing that. And And in different locations, different services will run that. In some places, it might be cardiology. In some places, it might be the care of the elderly team, just because these sorts of things get commoner as people get older. So it's about understanding, I guess, speaking to your healthcare professional locally, that might be a GP, it might be a hospital specialist, about what the local services are for their investigation of that. And they might have a really good service around that and around the management. The management is challenging. There isn't a specific cure for it. It's really about avoidance of triggers and also about management strategies to try and avoid the consequences of having, a low blood pressure when you stand up, for example. So because there aren't any specific therapies, but if there's particularly complex features of autonomic dysfunction, then it might be that the local service might wish to refer to a much more specialist service, such as the one at the UCLH. So I think it's quite a complex question in the sense that we don't understand it as well as perhaps we would like in the context of PBC, but we know it can exist and it can be quite debilitating. But speak to your local clinicians about what services are available to confirm a diagnosis of autonomic dysfunction, and then if it is particularly problematic and it can't be dealt with locally, then yes, certainly some patients might need referral to a super specialist unit such as UCLH.
That's great, thank you. Our next patient diagnosed with PBC 12 years ago with the AMA-M2 antibody and high ALP at 197. Been on URSO and have been having their regular yearly checks, ALP currently 145. Their daughter, who is now 42, has found out she also has the AMA-M2 positive but normal ALP. We've just touched on this earlier actually about confirming the diagnosis, and all the other liver tests were in range. So her ALP is normal at 73. The hepatologist she saw at her local hospital said she has PBC but doesn't need treatment yet. FibroScan score was 3.4. Does she have PBC? And what do you think about, do you have to have the high ALP for a diagnosis? And we kind of touched on that earlier, didn't we, with the other question?
Yeah, and I think, according to, and this always sounds like I'm sitting on the fence when I say this, according to current diagnostic criteria, you have to have a raised ALP. Now, might some people have very mild PBC with a normal ALP? That is possible. But I guess the challenge is, do we want to be biopsying everybody who has an elevated AMA to see if they have very, very mild PBC? Because most people won't have it at that time point. And the answer is no, we wouldn't want to be doing that, because that would be exposing some people to risk for no additional benefit. So at the moment, the accepted diagnostic criteria are that you need an ALP, where I think, the assessment has been thorough in the sense that they've done a FibroScan as well. So I think that's helpful, because what it tells you that there's no liver damage there. And so what it would suggest, particularly if she has the M2 antibodies, that she is at very high risk of developing PBC at some point in her life, and it would be sensible to have her ALP rechecked. We don't have evidence as to what the optimal interval for that is, but it's probably reasonable to do it once every year or so, because if the ALP does become abnormal, then she will meet the diagnostic criteria for PBC and can go on to therapy. So at this point in time, she wouldn't meet the diagnostic criteria. But I kind of understand what the clinician's saying, is that with the M2 antibody, at some point she will have it, but it's just at the moment, that's why she's not on treatment. I think if you've got a raised ALP, everybody should now be on treatment.
Great, thank you. So our next question is a patient that was diagnosed with PBC 3 years ago and are monitored by their hepatology team. GP has suggested they take a daily statin at 20 milligrams, not because they have high cholesterol, but because their Q risk is at 18%. Q risk is a calculation that estimates the risk of developing heart attacks or stroke. Is that right, in the next 10 years? Yeah, so I just wanted to clarify that as well. So the hepatologist has agreed this will be okay, although the decision to take a statin is being left with the patient. They've had a bit of read about the information that's available on side effects from the statins, which include fatigue, muscle aches and brain fogs, all possible side effects and all things that they currently suffer with, particularly the muscle and the joint pain. They've also read that the statins can increase blood sugar and cause weight gain, and it's taken the patient 2 years to lose a stone and bring their blood sugars down to 42. Would it be advisable to take a statin with PBC is one of her questions, and I think, to be fair, she's just a bit confused because the decision has been left up to her to confirm whether or not she would like to start it after having been given all the information.
Yeah, I mean, in some ways, I certainly, like, I sympathise, and I've probably put the onus onto people sometimes, and they might have felt the same way when I've had conversations with them. And I think, in some ways, if we look at the positives of this, is that clinicians are engaging with you and trying to involve you in your healthcare decision and not being overly paternalistic. But the slight downside of that sometimes can be that you're left to go, well, I don't know,
because finding the balance, isn't it? Yeah.
So I think it's encouraging that clinicians are having the conversations in the first place. So I think that's the first thing to say.
Mm-hmm.
The second thing to say is that the Q risk is there to try and identify from who would benefit from a statin in terms of reducing cardiovascular and stroke risk. And if you come out at being at risk, that doesn't mean to say that you will develop a heart attack or a stroke, but it means that you are at much greater risk of doing so. And the studies show that by taking a statin, on average, and that's the key word, on average, you're less likely to have a heart attack or stroke as a result of then taking a statin. What those calculations don't do, of course, is work out your risk or what the consequences are for you of developing side effects to the statin. Now, in relation to your PBC, I would not be concerned about offering a statin to somebody with PBC, and we recommend it for lots of our patients if they have high cholesterol or high Q risks, because actually having an existing liver disease does not make you more likely to develop a liver-related reaction to statins. And it doesn't really make you significantly more likely to develop any other reaction either. So you're at exactly the same risk as anybody, somebody who doesn't have PBC as developing a reaction. Now, like all medications, however, you can get side effects from it, and the ones that have been reported there, myalgia particularly is probably the commonest one. The thing is, I would say with the statin reactions is that most of them are reversible, in the sense that, you get the symptoms of myalgia, you stop the drug and it goes away. So you're not left with permanent changes from that, and significant liver reactions are really, really pretty rare. So I think, generally speaking, you're more likely to benefit from taking the statin than be harmed by it, which is how the Q risks are sort of calculated. And it is therefore offered as a recommended. This will be something that should benefit you. And particularly if you don't get any side effects. Now, the trouble is that you could take it and you get horrible side effects and would say, I wish I'd never done that. But at the same time, you just go, well, I don't want to take any risk of side effects. And then you suffer a heart attack or stroke in 10 years' time and think, well, could that have been modifiable? So this is where it does come down to a little bit of an individual decision in terms of how comfortable you are with managing that element of uncertainty. But certainly it's safe from a liver standpoint, or there's no increased risk from having PBC, and the Q risks are calculated to try and benefit people to protect their brains and their hearts into the future. So ultimately it does come down to your decision. But most people don't get these myalgias and the brain fogs. Most people, hundreds of thousands, if not millions of people in the UK, or it must be millions of people in the UK, are taking statins without any major issues, but a small proportion can get side effects. But as I say, the vast majority are reversible on stopping the drug.
That's great, thank you. Our next patient was diagnosed in January 2023. They've had pain in their right lower rib cage. Visit to A&E on a queried appendix, which was ruled out. No temperature, no infection, but their ALP was up to 152 from 130. Is this a normal pain with PBC, and how long does it usually last? They've had it for about 6 days now with no improvement.
So I think one of the things that was really striking to me is when the foundation did the surveys and did the word clouds about the sort of impacts of people living with PBC, is that pain came out really quite strongly, didn't it? In those sort of word clouds in terms of the impact it had on people's lives, sometimes even as big, if not more so than itch. But PBC itself doesn't cause liver pain, as such. People with PBC get pain, but those can be for lots of other reasons. It can be due to altered gut function. It can be due to gallstones, which we know people with PBC are more likely to get, or it can be due to associated autoimmune conditions like Sjögren's syndrome, pain in the joints, etc. So the first thing to say, I think, is that having PBC shouldn't cause liver pain per se. It's always important to understand that, could that pain be related to something else that is at least tangentially related to PBC? So an ultrasound to look for gallstones would be advisable if you've had pain severe enough to go into hospital, and gallstone pains would commonly occur on that right-hand side. But of course, you know, people with PBC, if they have thinner bones, are at risk of bone fracture. Bone fracture can give you pain in the right-hand side, particularly if it's in the ribs area. It can be musculoskeletal from other parts of the body, or pain on the right-hand side can also be due to impaired colonic function, bowel function. So I would say it's important to get an ultrasound scan, but you know, to look for gallstones, but to consider other possible causes as well, because just having PBC on its own shouldn't inflame your liver to the point of causing pain.
Oh, that's great, thank you. Our next patient diagnosed 2020 and has been taken Urso since then. Last year, their ALP numbers started rising. So in 2021, 230, 2022, 180, June last year, 250, September last year, 270. Everything else is normal. FibroScan September last year was good, and their consultant at George Eliot has now said they're eligible for second line, but permission has to be given at the Birmingham Hospital. They're still waiting for an appointment, but it has taken 6 months for that, and she's worried about the disease progressing. Any information that you can provide for that?
Yeah. So look, I think what that sort of brief vignette sort of talks about is some of the inherent delays within our systems at the moment, isn't it? Which is very, very frustrating for you as patients on that receiving end. What I would say is that I think the right decisions are being made, you know, in the fact that they've recognised that there's a persistent elevation of the ALP above the response criteria. So therefore, second line therapy should be considered. And we know from the UK-wide audit that the PBC Foundation was involved with that actually not enough patients are being considered for that. So it's good. Your clinicians are thinking about it. That's great. Okay. I can appreciate the frustration waiting that length of time for the approval, because it does have to go through a regional approval process through something called operational delivery networks, which exist in England. Scotland and Wales have a slightly different system. It's okay to ask to see where things are at with that. Contact the team and just say, can we get an update, please? And then, you know, it might be the delays at the Birmingham end, and it might be a case of, you know, they might need to just write a quick sort of like, you know, can we get an update, please? Can we get a definitive answer on this? Because I think, you know, I think 6 months is is a reasonably long time to wait for that back. And I know I've experienced similar waits as some people in South Wales as well for lots of reasons and pressures within the system, but it's entirely reasonable, you know, that's more than long enough to wait before chasing it up, if that makes sense. You know, so
and
please do.
That's what I was going to ask, is what's the best way for giving a nudge on that? Is that best way going back through their own consultant and asking for a nudge that way?
Yeah, I don't think it's I don't think it's for the GP to sort that out, as the GP's not been involved in that part of the process. I just contact the hospital consultant secretary and just say, I just wanted to know if I could get an update on that, because obviously if I'm going to go on to second line therapy, I'm keen to do it sooner rather than later. What I would say in terms of the concerns about disease progression, and this is not to poo-poo any concerns over delays, but actually if you've got a normal FibroScan, then that's reassuring that you've not developed progressive liver disease. So there's nearly always plenty of time to make these determinations, although understandably when you're on the receiving end, any delay seems interminable. But I think if you've got a normal FibroScan, then really the rationale for bringing that ALP down is to keep it that way rather than treat a high FibroScan score. So, you know, there's been no sign that you've got progressive disease based on that. And we know that PBC doesn't progress rapidly. It progresses slowly over a long period of time. So if you've got no significant scar tissue now, you're not going to develop loads in the next 6, 12, 18, 24 months by having an ALP of 200 odd. You know, we know many people with PBC have had ALPs that have been elevated for a long time before they're diagnosed. And not everybody will develop damage in that period. And certainly you wouldn't expect that over a short period of time, like 6 months, 12 months.
That's reassuring, thank you. We have a patient who's just about to start Urso, and their GP has said 3 tablets at night, but after reading the instructions that came with Urso, it states that for people with PBC, take 1 tablet 3 times a day. This is something we often get questions about, is when to take the Urso and how to take it. So after 3 months, to then start taking 3 altogether. So she found that a bit confusing, and what's best? Is it best to take it throughout the day to let your body adapt it, or okay to take it all in one go in the evening?
Yeah, I think if you look at the way drugs are produced and licensed, that they do things called pharmacokinetics. So they look at how the drug is absorbed in the system and what is optimal. But we know that aerosol is quite a long, what we call half-life. So actually, you can give it all in one go. The slight challenge with giving it all in one go is that you might be slightly higher risk of developing some of the side effects, particularly diarrhea. The downside to taking something 3 times a day is studies very effectively show that if you ask anybody to take something 3 times a day on a permanent basis, is that you nearly always forget one of the doses because we're all busy and you just forget. And so, to be honest with you, I tend to prescribe it once a day. But I say to people, like, if you get any side effects, if you get any diarrhea, any headaches or anything funny like that when you start taking the medication, then split the dose for a period of time. And then sometimes you can build it back up again then. So I think you pay your money to take a choice. There's no real harm to taking it all in one go. Most people will tolerate it just fine that way, but some people will find that they'll have some diarrhea as a result of that, in which case you either reduce the dose or you split it, and that often solves that problem. But the benefit of taking it all in one go is that you just do the same thing all the time, and you know I just take it before bed, and then you're in that groove of taking it, whereas 3 times a day, the middle of the day one nearly always goes by the wayside, doesn't it?
It's the routine, isn't it? Getting it into your routine as to when it suits best for optimum take-in, So our next question is from a patient who lives in Spain, and their liver doctor in Spain doesn't know whether they can keep taking their Urso while breastfeeding. She has a doctor from previously living in the USA, but they can't advise when out of the country. Do we have any information for breastfeeding while having PBC?
Yeah, I mean, I think we've used Urso for a long time in pregnant women. So we use it to treat obstetric cholestasis. So there's no evidence that it's harmful in that regard.
That's great. Can you advise which over-the-counter medications and vitamins should be avoided with PBC?
Yes, so I think this is a broad question, really. It's not so much about with PBC. It's applicable to anybody, really, in the sense that it's always really important if you're taking something that's over the counter that it's not liver toxic, particularly if something that you're buying online, because there are some supplements, even described as herbal supplements, which can be hepatotoxic. And so it's really important that you don't take anything that is bad. Most of them are not. And the question is what supplement you're taking and for what purpose. So in general, I'm not a huge fan of supplements just because I think a lot of them have extremely poor evidence behind their benefit in the first place, and they can be they can be quite expensive. And if it's something that if you're clearly lacking in B12 or iron, then you should be able to get that prescribed at an appropriate dose to sort of correct any major deficiencies. So in general, if you're buying from a reputable deal, if you're going to Holland Barrett or you're going to Boots or something like that, then you're you're going to be getting something that is largely safe. But certainly there's things like Black Horse, which have been used to treat depression, things like that. Some of those things have been shown to be hepatotoxic. So you have to be a little bit careful with certain supplements, and just to be aware of that issue. And if in doubt, you can always ask your doctor about whether this is, and they can check, or you can check with the pharmacist when you go into the next medication pickup. Pharmacists are normally very happy to give additional advice, and they are actually the uber experts at drug safety. So if in doubt, ask somebody that's prescribing any other medications for you to make sure that there's A, compatibility, and B, no risks of liver toxicity.
Not no risks. That's brilliant, thank you. We've also got a sort of general question around taking antibiotics as well. So it is quite a general question around taking antibiotics for an infection and the risk that involves whilst having PBC, if any.
Yeah, I think if you've got an infection for which antibiotics are genuinely indicated, that should not be a preclusion to that. Some antibiotics are more likely to cause a drug-induced liver reaction than others, but again, there's no clear evidence that having PBC or autoimmune hepatitis, for example, increases that risk of developing a drug-related reaction to medications. So most drug reactions of the liver are what you call idiosyncratic. So it's something that your body just doesn't like. Now, I know I guess philosophically, you might think that having an autoimmune condition makes you more likely to generate an immune reaction to something else. We don't have evidence to say that's definitely the case. So, if a medication is indicated, then we don't have anxiety about the use of antibiotics.
That's great, thank you. I'm just going to move and take a question that we've got in the room here. AMA is strongly positive, greater than 200 units. Honours, so 250 milligrams. Next blood test due end of April. Will it come down? Hopefully. Is this very high?
So I guess the question is that, are they talking about the AMA being more than 2,000, or we're talking about the ALP being more than 2,000? I mean,
AMA, as it says, my AMA is strongly positive. Yeah.
What's interesting is that the AMA, we call it the titer, which is the degree of 1 into whatever it is, 2, 5, 60, whatever it'll be. It's not strongly correlated with disease severity or response to treatment. So we don't use that as a marker to see how well you've responded to your medication. It's the ALP response is the key bit. So we know that about 70% of people will have an improvement in their ALP. So we'd expect the majority of people will have an improvement. The only thing I would say is you're on quite a small dose of urso. And so now that might be for tolerability reasons, for example, and some people do start very low and build up, I think. But,
I noticed that too, yeah.
Yeah, but I would certainly, and some people, when OCA first came available, in our local area, we looked back at all the people who were on urso and looked at their doses, and some people were historically on very low doses from years and years and years back, but their ALP is completely normal. So if your ALP has responded, it doesn't matter. But the general principle is start at the higher dose to bring it down to normal, and certainly if you're not getting to normal, then make sure you're on that weight-based dosing calculator on the web page.
Just a reminder to go and you can go and check that on the website as well. That's great,
so,
thank you.
The one fun thing to say is urso works a bit slower than the other drugs we use to bring the ALP down. So it can take a good 6 months to see the peak effect, and sometimes even up to 12, but the bulk of the effect is seen at 6 months. So, if you only just started it and you have a blood test end of April and you've only started in February, don't get too downhearted if you haven't had a great response. But I think, similarly, if you haven't had a great response, I would certainly recommend going on to the weight-based dosing to give yourself the best chance of having that 6 to 12 month treatment response.
That's great, thank you. I'm just going to move over to some of the questions we're getting live in on Facebook just now as well. We have a patient who's just been diagnosed with PBC, blood test 6 months ago, and they've started on urso, and just noting that they're feeling upset about it. So first thing I would say is please do reach out to us, give us a call on the helpline, chat it through with someone just about your diagnosis and anything else that we can help you with. But Dr. Yeoman, what would your advice be to a newly diagnosed patient like that?
Yeah, I mean, I think it can be a really uncertain time, isn't it? I think you can read lots of really scary things about PBC, and that's not, that's not the case for everybody. There's a huge spread of disease severity and symptom severity in PBC, and again, that's not to invalidate anybody's experience who have really severe effects, but some people have a very mild disease course. Not everybody develops progressive liver disease, and not everybody gets profound symptoms. If you are suffering from profound symptoms, then the foundation site and advisors there can be really helpful and put you in touch with the community that can help support you on a regular basis and provide reassurance around things. And the only other thing from a medical standpoint we always say is it's really important that you've had a thorough assessment, that if you're on the medication, you're on the right dose, you're having it appropriately monitored, and that ongoing monitoring of the severity of your liver disease is undertaken. So as long as all those things are happening, then for many people this is an entirely manageable condition. But if you are suffering from the additional symptoms, particularly the itching, it's really important that you do flag that up to your doctor so that you can have additional medication to treat the itching. Don't suffer in silence with that. The fatigue, as we know, is much more challenging to treat. We don't have any medical therapies for that, but again, there are resources on the foundation side that can help you support you manage that when you're living with the fatigue. So I think being involved with these sorts of things, coming on the Facebook groups is really helpful. It's a start of your journey learning more about your condition to help you manage it. But as I say, for very many people, it can be entirely manageable and doesn't always cause serious liver disease.
Yeah. As a patient myself, I would say information is absolutely key. Find a good source to up-to-date information. So the Foundation's website. Also, if you're interested in the community terms and meeting other patients with PBC, contact the Foundation. We'll see if there's a group in your area. If not, there's regular online meetings that a patient can join from any area. There's always something happening. So please do reach out to us, and we can have a chat with you as well. We have a patient who has, I'm just checking the questions here on Facebook. I've got a question asking, is it usual to stay on Urso post-transplant? I'm 11 weeks post and still taking, but no others haven't taken it since.
Yeah, I think, again, I think we don't have really good evidence in terms of how well that functions in terms of prevention of recurrent disease. But it's not uncommon for people to remain on Urso to do so. So as long as you're tolerating that, I think that's a perfectly reasonable thing to do.
That's great, thank you. We've got a question asking about your thoughts on weight gain while taking Urso. Diagnosed 3 years ago and have had to increase the daily dose to 1250 milligram during this time, and recently started to remove the medication from the capsule and take it with water, thinking the capsules might be the issue. Any thoughts?
I think the tricky bit with taking things out of the capsule is you might affect the absorption of the drug. So the reason why the drugs are produced in capsules is because that particular brand because there are several brands of Urso, they require absorption in a certain way, and so sometimes the capsule is to make sure that they are absorbed in the right part of the gut. So generally speaking, if it's in a capsule, I probably wouldn't do that because it might be absorbed okay, but it might limit the absorption of the drug. I think there are relatively few medications that cause significant weight gain. The trouble with a lot of, when you look at package inserts about things that medications can do, they're written from a very sort of medical legal protection point of view. So that any symptom that is reported when somebody takes those drugs often makes its way into the product literature, irrespective of whether they are causative or not. And so, don't get me wrong, there are certain medications that can, cause weight gain, but they are relatively few and far between. And so if there's a real element of doubt, you can always change preparation of Urso. There are others available. So,
yeah, I was just going to ask that, because you can get the tablet form as well, can't you? The pressed tablet form rather than capsule.
Yeah, exactly. Yeah. So you can get pressed tablets. So, if that's a real ongoing concern, it might be an opportunity to switch. And you generally find that it doesn't make much of a difference, but sometimes it just puts people's minds at rest that you've tried something different, that you've included that it's a preparation effect. But certainly it's not a drug that we really see causing a lot of weight gain. But I certainly wouldn't break the capsules up because it might affect the absorption. And so, considering a switch of preparation is probably a better option.
That's good, thank you. We have a question asking, can PBC cause hot flushes similar to menopause flushes? We've kind of covered earlier on when we were talking about the temperature issues. Patient 62 and not menopausal, but has started having hot sweats in the evening. They have PBC with compensated cirrhosis and gallstones.
Look, I think any new symptom of hot flushes should probably be reported, and sometimes that might require additional investigations based on your GP's knowledge of other aspects of your medical history. So yes, as Mo's alluded to, and we spoke about earlier in terms of autonomic dysfunction, it can be related to that. Some people with cirrhosis get a dysregulated temperature, so you can get flushes for those reasons. Sometimes GP might want to do hormone profiles. So I think it would be reasonable to report that, because I wouldn't blame it on the PBC per se, but the occurrence of the cirrhosis might have an impact on your temperature regulation, but it might be something completely separate. So I would definitely report that and get that looked at separately.
That's great, thank you. A question about, I don't know if I'm pronouncing it correctly, Meniere's disease, MENIERS disease, associated with PBC Is it associated with PBC? And if so, how is it diagnosed?
So Meniere's is an inner ear dysfunction. It's not generally considered to be a PBC manifestation. It's a really reasonably common condition. It's normally diagnosed by ENT people who will do sort of particular types of testing to sort of see if they can trigger the Meniere symptoms through postural changes, etc. But it's treated by drugs that don't have any impact on your PBC. So yeah, it's not something that I would consider to be related to your PBC. It's just an unpleasant thing to have to put up with. But it's normally diagnosed and managed by either GPs or ENT doctors.
That's great, thank you. I'm just going to move to a question we have in the room here. Patient diagnosed 2 years ago and a responder to urso. Wonder how often I should be having my bloods checked, worried that they might stop responding. So it would be good as well just to have a sort of general understanding of how often you would recommend so not just blood tests, but maybe thinking about fibroscans and that type of thing as well.
Yeah. Again, you'd have thought there'd been a sort of a well-established schedule of this, but I think nobody's ever really established a specific schedule. But I think we know that, generally speaking, once you've responded to a therapy, you tend to stay responded to it in the vast majority. There are exceptions, but in the vast majority, you stay responded. And so we don't want to over manage and over investigate people who've got very stable disease. And so, from my perspective, it depends how long you've had it. If it's only 2 years ago, I'd probably do 6 monthly blood tests. And then, if it's been that way for another couple of years, I'd probably, and you've had normal liver tests for 5-6 years and nothing else is changing, then I'd often go to yearly blood tests. So that's what I would normally do. And again, there's no hard evidence base around that. But, in terms of how we understand the drug works and how once you've started to respond, how the vast majority should continue to respond, that's, I think, a fairly pragmatic and sort of sensible way to go forward. In terms of FibroScan, Mo, I think that's something that we do really need a lot more data on, because I think certainly I think we need to get to the point whereby, and I think this is where care bundles come into it, is we need to start really making certain that more people have had a liver fibrosis risk assessment when they've got PBC, because we biopsy very, very few people now to make a diagnosis. So we can't just rely on plain ultrasound scans to determine how much damage is there. So I think baseline fibroscans should start to become the standard of care, although they're not yet. In terms of how often they should be repeated, I think it depends on a couple of factors, really. The first will be how long you've had PBC for, and what your first fibroscan was. Because if you've had it, say, for 20 years, and your first fibroscan was normal, and you're an ALP responder, there's probably little value in repeating it, in all honesty. And if you were going to do it, 4 or 5 years would probably be fine. If you're 35 years of age and you've got an ALP of nearly 1,000, then you might be checking that once a year, for example, to see if there is significant progression. So I think the interval at which we should certainly establish, a FibroScan score at baseline or soon after diagnosis as possible. And then I think the interval thereafter, I think, should be generated by how long you've had the condition for and how bad your ALP is, whether you're a responder or not. And that range could vary between yearly and 5 yearly to, in some people, never.
That's great, thank you. I've got one last question from Facebook just before we finish up for today. So we've got a patient who has PBC and autoimmune hepatitis. Just noting that they're very scared having both. They're stage 4. What would be your advice in terms of what she should be asking our clinician about at this stage?
Yeah, sorry, Mo, can you just repeat that, because my internet glitched a little bit.
The patient has PBC and autoimmune hepatitis. They're very scared about it. They're stage 4, just concerned about having both conditions overlap. What would be your advice on what they need to be prompting their clinician for in terms of tests or any ongoing treatments?
Yeah, so I think, if you got both aspects, that what you wanted is that you've got control over both of them as best you possibly can with the appropriate therapies. And so, make sure you're on the appropriate weight-based dosing of urso. And if the ALP is not coming down appropriately, consideration of those second-line therapies. So, in other words, do I need second-line therapies? And, to make sure that the ALT is as well controlled as is possible. And obviously with the ALT, we like to get that into the normal range. At the moment with ALP, we try to look for it being less than around 200. But I think if you have multiple pathologies, there's potentially an argument to try and get it to normal. But although we don't have hard data for that at the moment, I think the key messages are right weight-based dosing of urso, get your ALT under control, and make sure you're on the right treatments to do that. And then again, monitoring. Some people will need a biopsy to monitor if you've got an overlap syndrome. Or again, it might be possible to monitor, the degree of damage to the liver with FibroScan. I think that's the other important thing, because we know a small proportion of people will progress their liver disease, even though their liver tests respond really nicely to urso or the treatment for the autoimmune aspect. That's
great, thank you. And I would just say to that patient as well, please give us a call on the helpline and we'll have a wee chat through with you as well and see if there's anything else we can do to help on a support level as well. We have had some great questions today. We've got through a lot of questions as well. Thank you so much for joining us today. We really do appreciate your time. And just to say to everyone as well that just to remember to check PBC TV on YouTube, because each week we do upload these Q&As onto YouTube as well. So they're always available there, as are all the old ones. I think we're up to well over 80 Q&As on our YouTube channel now, which is just brilliant. So thank you very much for joining us, and we'll see you again next week.
Good to see you all.
Thank you. Take care. See you soon.
Bye now.